Um, so let's start our COVID ED rounds update number 5. I'm going to hand over to Neil for the update. Thanks, Neil.
Okay, thank you, Stuart. And thanks to Megan and Rhonda for an excellent presentation on checkpoint inhibitor toxicity. That was really informative and really high quality presentation. And thanks to Sean and Aaron for and the PLP for setting up these rounds. I think they've been really fun to participate in, and hopefully people are finding them useful. And thanks in advance to Jen for her expertise in helping with the COVID update today, and Eileen from the wellness group. So I just wanted to quickly summarize the provincial data. So as usual, when I write something down, it becomes immediately incorrect because it's out of date. So almost a little over 300 new cases since I wrote this. So we're up to 3,401 cases in the province right now. We're sitting at about a 5% admit rate and 1.4% ICU admit rate. The 5% is just inpatients on medical wards, and then an overall fatality rate of 2%. You can put up the next slide, please, Aaron. So there's been, I just looked at the forecasting yesterday, and I know Eddie has some more maybe up-to-date information with a more in-depth conversation with Stafford Dean and his group at a clinical department head meeting recently. The forecasting is now, I went out to mid-May, and the graphs I've shown you in the past show low, moderate, and high projections. And that number of 176 inpatients by May 15th is the high line. So that's the upper limit of what we could possibly expect. And I think the most probable projection is well within that. So the capacity I've listed at 680 there is the inpatient capacity in Calgary zone, the first stage of the surge capacity. So we're well within our capacity for inpatients. And then the ICU beds occupied the high line. The most we would expect is 61, and their first stage capacity is nearly 100. So we're well within our capacities for inpatients and ICU. So I just, I think we've done quite a bit of work in the region in preparing the people and the spaces and the equipment and the processes for managing the pandemic. And clearly it's mostly underutilized right now. And so I just was reflecting on this as on my last shift. We just get the next slide, please, Aaron. And I just wanted to highlight some areas where we've had some concerns. The first one is in delayed presentations to the emergency department. So I think most of us have probably seen some presentations to the emerge that probably should have occurred in the days before they actually did. And Eddie and Bruce McLeod and a QI group that has the support of senior HS leadership have embarked on a QI project that I wanted to highlight. So if anybody is seeing any presentations to the emergency department and urgent care centers, Eddie, correct me if I'm wrong, this project extends to urgent care as well?
That's correct, Neil, thanks.
So any presentations of patients that to the emergency department or urgent care that look like there's an adverse outcome that has happened because of a delayed presentation. So the patient felt unsafe to present to an emergency department or urgent care center because of the COVID pandemic, or our processes put them in a disadvantaged state. If you notice anything like that, then please take a few minutes to fill out an RLS. And we're collating and collecting these possible errors just to examine how our preparations for the pandemic might be affecting quality. And just on another sort of closely related topic, I was on shift the other night, and I was just noticing how changes in our routine. So the patients being sequestered in a hot zone in the emergency department, they're no longer have the benefit of constant contact with a bedside nurse. They may not be monitored in a way that we're used to. We don't have the ability to examine them the same way we usually do. Sometimes it's not possible to disrobe them properly in the hot zone. There's issues of acoustic and visual privacy that impact our ability to assess our patients. There's a distinct lack of collateral history. There's no more visitors allowed in the emergency department. And so I, for one, am finding it difficult to figure out why some people are in the emergency department. And you just realize how important it was to have a family member at the bedside helping with explaining what's different from usual. And all these things, in addition to the cognitive load of trying to keep ourselves protected from catching infection and spreading the infection to other people, the use of the PPE, and just the additional stress has put a cognitive load that I, for one, find difficult to incorporate into our usual practice. So I just wanted to sort of shine a light on these potential areas for making mistakes in the emergency department. And I made a few of them on my last night shift, and I thought it might be valuable to highlight those for everybody else, and just also highlight that QI project for that Bruce McLeod and Eddie and others are doing. So please use the RLS system if you're encountering patient presentations that were delayed because of the pandemic response. And just lastly, before we get to Jen, I just wanted to talk a little bit about the algorithm, the admission algorithm. There's been quite a bit of work on developing an algorithm that helps us decide who is going to admit various patients based on their risk of having COVID and their goals of care and the severity of their illness and various parameters of their clinical presentation. It was developed at the Foothills. It's in use at the Foothills. The algorithm's in use at the Foothills. The admissions form, which is useful, very useful, as I mentioned, I think last week, it's very useful for admitting services downstream to figure out why we swabbed a patient in the emerge and why they're on contact droplet. And it will help them to de-escalate their isolation procedures down the road. So it's crucial information. They've asked us to fill that form out. And so it can either be filled out by the emerge doc or the admitting physician, but it should be part of the chart. Both the algorithm and the form have had uptake at the other sites that has been variable. So I think it's in widespread use at Rocky View and South Health Campus. The algorithm is different at PLC because they have a hospitalist COVID pager there, but the basic framework of the algorithm is similar. So I don't want people to get too hung up on using the form of the algorithm. You should just listen to the site direction you're getting from your site chief. But all the forms are on the U of C website, and they should be linked to the order set. And then just lastly, a reminder of the assisted self-isolation site, which is the hotel up by the airport. They now have increased capacity. They're taking 4 people a day. So just remember that as an option for people who are well, don't need to be in hospital, but need to be isolated because of vulnerable housing. And that's all I got. Thanks very much, Stuart.
Perfect, Neil. Thanks a lot. Just great things to highlight. I'm just going to move on now. This is the agenda. We had the update from Neil. We're now going to move into the clinical aspect, which is the end of life care for the patient dying of COVID in the emergency department. And then we're going to have the normal Q&A with Sean afterwards. Please, just a reminder to put your questions into the Q&A section. Just check if somebody has asked a question that you think is important, and then click the little like, and it will move the question up in importance so that Sean can see what's important to us. And then the wellness update from Eileen, and then we'll wrap it up. We may run over a little bit. We're planning 45 minutes, but it may run over a little bit today. I just apologize for that up front. Okay, and so we're just going to move to the next slide, please, Erin. So I'd just like to introduce Jen. As you know, she's one of our members of our department, but she is also the medical director of the Intensive Palliative Care Unit and a fellowship-trained doc in palliative care. Jen?
Thanks, Stuart. Good morning, everyone. I'm going to talk to you today about providing palliative care and end-of-life care for patients who are dying of COVID-19 in the emergency department. A lot of the things we're going to talk about today are obviously applicable in other palliative care situations and providing end-of-life care in other situations. There's a few specific things around COVID-19, but a lot of this is general, good primary palliative care. So I just wanted to start by reminding ourselves, if you can move to the next slide, actually, Erin. Sorry, I'm used to being in control of my slides. It's going to seem a bit obvious and trite, but I find it helpful to remind myself and to ground myself, and perhaps you'll find it useful as well. You know, the ethos of emergency medicine is to save lives, and despite this, it's very important for us to remember that death is a normal, natural part of life. And no matter what we do as emergency physicians, in some circumstances, some of our patients are going to die, and that's okay. And I just want to remind us all that I know that we are all caring clinicians, and the small things that we do on shift caring for our patients and our staff are meaningful, and they have a significant impact. And also that we already have palliative care skills. This is something that we do on a regular basis as emergency physicians. And this opportunity is really to refine those skills and to excel at them. So I'll get you to move to the next slide, Erin. So we're just going to talk a bit about communication and goals of care conversations in the emergency department. We're going to talk about symptom management as it pertains to COVID-19, and then we'll talk about the resources that are available here in Calgary from a palliative care perspective. Before we move to the next slide, I'm going to talk to you about a framework. We all know how to have goals of care conversations. We all know to check the green sleeve. We all know to look for a substitute decision maker. I don't need to talk to you about those things. What I want to do is give you some examples of language that I find helpful, that I use, and that I use for teaching residents that you might also find helpful. And then I would encourage you to find what works for you, to practice it and rehearse it, and have it ready to go for these conversations. It makes it a lot easier when you have a script that works for you, and it doesn't have to be exactly what I'm going to share with you here today. And I'll get you to move to the next slide. The other piece is that everything I'm talking about now has been put into a cheat sheet document that will be uploaded to the website at the end of today's talk. And it's something that our palliative and end-of-life care group has put together to help all clinicians have these conversations, not only in the context of COVID, but especially in the context of COVID. So the important parts to having a conversation around goals of care are to set up the conversation. And I usually say something like, I'd like to talk with you today about how to best care for you with this illness. Is that okay? And it's really important to check in and ask patients what they know about what's happening to them, because you're going to get wildly divergent answers, and it allows you to fill in those gaps a lot quicker. So I might ask, what is your understanding of what's happening to you? And some people might say, I understand that I think I have COVID and I'm very, very sick. And other people might say, you know, I have no idea what's happening to me, and you'll need to adjust your knowledge and the information that you give to somebody accordingly. Then I'll usually consider the prognosis of the situation at hand, and then I will offer to tell people what I think is happening, and that's part of closing that gap as well. Silence is obviously a very important communication tool when you're talking about goals of care with patients. I might also say, have you already thought about what's most important to you in this situation? And then it's okay for us as clinicians to make a recommendation around goals of care. The other phraseology that I really like for these conversations is something called I wish, I worry, I wonder. And I might say something like, I wish this wasn't happening, but I'm very worried that you've become quite sick with COVID-19, And I'm very worried that with your other health conditions, that you might get very sick quickly and you're at risk of dying. I think it's important for us to prepare for that possibility. And then I would talk about, I wonder if we should think about focusing our efforts on aggressive medical management. So it really allows you, the wish part allows you to align with the patient's values. The worry part allows you to sensitively share prognosis. And then I wonder allows you to make a recommendation in a gentle and compassionate way. I'll get you to move to the next slide. So when you're actually discussing the different goals of care that we have here in Alberta, I would encourage you to speak about them generally and in alignment with patients' goals. Patients don't necessarily need to know if they're M1 or M2. What they want to know is what the approach is for those different categories. So again, these are examples of language that I use and that I teach with our residents. And you'll see that this is actually in print on that document that I referred to. But I might say something, like, if I think that there's a reasonable chance that you will survive with all the available treatments that we have, including putting you on a ventilator, including doing CPR or restarting your heart if it were to stop and taking you to the intensive care unit, are you willing or interested to try those things? We call this resuscitative care. And how does that sound to you? How does that plan sound to you? Gets a little trickier with the M and the C pieces, and that's why rehearsing it is a really useful skill. I might say, I'm really worried if you get sicker that using a ventilator is not going to be likely to help you survive or get back to the quality of life that you've told us is important to you, especially with your other medical conditions. So I want you to know that we're going to do everything we can to aggressively support you with medical treatment, with medications, with oxygen, with IV fluids, and also focus on your comfort. But we wouldn't put you on a ventilator or take you to the intensive care unit if you were to get worse. And we call this medical care. And the same thing for comfort care, again, some phraseology around that. I want you to know that we're going to keep taking care of you the best that we can. I'm very worried that you're at risk for dying. I'm hoping you're not going to get worse. But of course, we're going to focus on your comfort as long as you're with us. Every decision we make, every medication that we choose is going to be focused on your quality of life and comfort and allowing a natural death when it comes. We won't be focusing on life-prolonging measures. And this is what we call comfort care. So I hope you find that helpful just to hear some of the language that I use, and maybe some of it resonates with you and maybe it doesn't. But you can refer to this afterwards, write down your own script about how you want to say these things. Next slide, please. I'd encourage you to avoid saying things like referring to the patient in a very impersonal manner. A patient with this stage of COVID is likely, has an X percentage of dying. Please, I would encourage you not to say there's nothing more we can do. That really just engenders hopelessness for everyone. The other important thing around having these conversations is not to give that sheet of paper with the goals of care, designation, description, and orders to the patient. Walk away and ask them to choose from it like it's a menu in a restaurant. These conversations have to be had in context with the situation and with support from a physician to align the right choice with a patient's prognosis and their values. And you don't want to say things like, don't worry, you'll die quietly and peacefully with these drugs, or telling people that they should be strong for their family, which also can make patients feel very guilty about what they're experiencing when they actually have no control over the situation whatsoever. I'd also encourage you to avoid saying things like we are withdrawing care or we should step down to comfort care, which again implies that comfort care or medical care is inferior in some way, when really it's different, with a different focus, and is just as valuable and just as important in the right situation. And the other question I'd ask you to reconsider if you do use it is saying, would you like us to do everything? Again, most patients when they hear this are going to say, well, of course, I want you to do everything. And everything means something very, very different across these different goals of care. Next slide, please. These are just some recommendations, again, some phraseology that you might find helpful or you might want to think about or practice for your own conversations. Reminding yourself to introduce yourself as the emergency physician, apologize for the fact that you can't, talk to the families in person if you're speaking on the phone to a family member. Remember, these patients that come in have nobody with them. there's 4 people in a room with PPE on and masks. They cannot read our facial expressions, and it's isolating and terrifying. So it's very important to identify yourself. It's very, very useful. I often say things like, I hear that you sound very, very worried. Do you want to tell me a little bit more about how you're feeling? And they might say to you, I'm worried about dying. They might say, I'm not worried about dying, but I'm very worried that my son is not going to be able to talk to me, or my dog is in my apartment and nobody can go and take care of them. I hear that all the time. So it's important to name the worry, ask them a little bit about it, and then offer, reassurances. We will not abandon you. That's a very common fear for patients who are at end of life, that they will be alone and abandoned. And it's important for us to communicate that. I'll always say something like, I'm very sorry your loved one can't visit. Please know that I'm going to call them and update them frequently so they know what's going on. And again, that I wish, I wonder, I worry language is also very important. I wish this wasn't happening. I'm very sorry to have to tell you this. I'm worried that things are changing for you. And I wonder if we're going to have to change our focus of care. Yeah, so those are just some recommendations that maybe resonate with you. You can go to the next slide. So that's really, a very brief primer on goals of care conversations in 7 minutes or less. I'm happy to talk more about that if that's something you want to contact me about and practice language, and I'm happy to do that as well. I want to talk a little bit about the symptom management for adults with COVID-19 who are receiving end-of-life care. You'll also find a document that we've put together provincially to support clinicians who are not palliative care physicians who need to provide end-of-life care for these patients. And again, these principles can be applied in other areas for dying patients, but are specifically going to address the symptoms that we're seeing. So this document and these recommendations really are geared towards people where we think death is anticipated. They can occur concurrently with medical management. We have now in Calgary palliated a few of these patients, all as inpatients. I'm not aware of us being involved with any cases in the emergency department yet, but perhaps one of you has with palliative care, I'm not sure. I'm happy to hear about it. A lot of these patients, die after a prolonged course in the hospital, some very easily with opioids and a little bit of sedation, and some have a more classic hypoxemic respiratory failure death of an agitated, significant dyspnea picture, and they require palliative sedation, which we're going to talk about. There's some literature that's coming out of the UK already that sort of describes the common symptomatology. None of it's a surprise. The most prevalent symptoms are going to be breathlessness, agitation, sometimes drowsiness, pain, and delirium. Next slide, please. So we'll talk a little bit about dyspnea, and a reminder that dyspnea is a subjective awareness of breathing. It is not based on respiratory rate or oxygen saturation level. It is how the patient feels. We have opioids are our mainstay of treatment for dyspnea and palliative care and end of life. And we have multiple randomized controlled trials and systematic reviews that tell us that they significantly reduce breathlessness, either orally or parenterally for advanced disease. They don't hasten death, and they do not cause respiratory depression in this context with the right dosing. How they work is a little bit not fully understood, but essentially, there's some thoughts around the fact they reduce the work of breathing, but they don't alter alveolar ventilation. We think that they probably alter our central perception of breathlessness, and that's usually how I describe it to patients. And they also probably alter peripheral opioid receptor activity in the lung and decrease anxiety. It's important to know that the doses that we use for dyspnea are a little bit lower than analgesic dosing. Next slide, please. So just a reminder, even when you're palliating patients with dyspnea, to avoid AGMPs, and the one that's probably most relevant for us in the ED is extubation. So if you've intubated somebody and they are dying and you change them to C2 goals of care, maybe consider weaning the ventilator with the respiratory therapist, but not extubating the patient while using medication. So of course the risk there is that the patient might cough as they're being extubated and expose everybody else. Next slide, please. So, you know, we use opioids. The dosing is about half what you would start with for analgesic dosing. Either morphine or hydromorphone are very, very appropriate. And then you titrate from there. So in the ED, I'd probably schedule it Q1H PRN. And if you think they're going to be in our department for any length of time, which I know is not really happening right now as these patients are being moved out, but the dying ones may not be if we think they're truly in final short hours. Please have a low threshold for scheduling them around the clock dosing as an opioid. So Q4H or Q6H if they have renal failure or they're quite frail or elderly. Next slide. Oh, and I should just mention around that story that we don't typically use fentanyl for this because it's so short acting. And in an opioid naive person, you're not going to start them on a fentanyl infusion for their dyspnea. So the longer acting opioids of hydromorphone and morphine are a better choice for this. Next slide, please. So refractory dyspnea. So let's say you do this and you titrate it up and the patient is still able to communicate with you that they are in a lot of respiratory distress. You might use small doses of midazolam for this. There's often a lot of associated anxiety with significant dyspnea. You might consider ketamine. At this point, I'd suggest that you strongly consider calling palliative care. In this scenario, and what we've had to do for our inpatients and for other hypoxemic respiratory failure patients is very quickly initiate palliative sedation. And I'm going to talk a little bit about that a bit later in the presentation. Next slide, please. So agitation delirium, also very, very common. You know, a lot of times you're going to know what the cause of it is. If you're not, just be mindful of the fact that even in comfort care, if you think a patient has, you know, more than short hours to live, sometimes a workup of agitation or delirium is indicated, and correcting the underlying etiology can still be very good symptom control. Again, if it's a true severe dyspnea, COVID case, and they appear to be dying in front of you, then this probably isn't relevant. But just a reminder in the palliative care world that it can be very appropriate to work up delirium. So you would start with Haldol, low dose, schedule it, and Q1H PRN. And then we move to methyltrimeprazine or Nazanan if Haldol is not helpful. It's a much more sedating medication, a dirty drug that targets a lot of pretty much every receptor. But when you want that sedating effect, it can be very, very helpful. Next slide, please. So again, with refractory agitated delirium, this is when we start using the benzos, and we have a pretty good evidence that suggests that benzos at very end of life can be useful. We tend to avoid them earlier on in end of life care for delirium because they actually can make things worse. But at very end of life, in addition to a neuroleptic, it can be very, very helpful. And again, this is a scenario where I'd really encourage you to call palliative care. And again, we often will move very quickly to palliative sedation in this setting. Next slide, please. And I'll talk about the palliative sedation in a little bit. So death rattle at end of life, just a reminder around secretions. So they really come from there's two different kinds. The first one are upper airway secretions. That's what we call the death rattle. And it's related to weakness and inability to clear things. They're very noisy, but usually the patient is unresponsive and comatose at this point, and it's more distressing for family if they happen to be at the bedside and caregivers. And it really heralds that it really sort of heralds that death is imminent in final hours. And those types of secretions are somewhat made better by the anticholinergics. And so you can start with glycopyrrolate or scopolamine if you want something more sedating because it crosses the blood-brain barrier. If you're in a pinch and you can't get those medications, you can also just use the atropine ophthalmic drops under the tongue. The bronchial secretions, which we are potentially likely to see with COVID-19, are much more difficult to treat. If you think somebody's volume overloaded, you could consider, a rescue dose of Lasix. But just know that those lower airway secretions are not well treated with glycopyrrolate or scopolamine. Next slide, please. Pain, this is well within our wheelhouse. I think just a reminder for starting doses for hydromorphone or morphine, and again, having a very low threshold to schedule it around the clock for these patients. And just a reminder, Most of the time in these patients, you're going to be using IV or sub-Q medications. If they are taking something orally, just a reminder of the conversion ratios for PO to IV is 2 to 1 for both morphine and hydromorphone. Next slide, please. So for a patient that comes in already on opioids, you're going to need to dose them differently. The same thing that we do for our patients who come in with other types of pain. So if they come into you, for example, I have a little example on the right-hand side of somebody who comes in on some hydromorphone Contin twice a day, and maybe they're able to tell you that in the previous couple of days they've needed to take a bunch of extra doses. So you need to add that all up for a total morphine equivalent daily dose, or a total 24-hour dose of their opioid, and then redivide that up into your interval dosing of Q4H or Q6H, and then calculate a new breakthrough for these patients. And that new breakthrough can either be 10% of their total. It typically is calculated as 10% of their total daily dose, and then you titrate from there. If you have somebody coming in on their Contin and you order for them, 0.5 of hydromorphone to control their pain, it's not going to work. So just be mindful that you need to be aware if somebody's already opioid tolerant, and then adjust accordingly. And this example, of course, is for oral opioids on the right-hand side. If they could no longer take that orally, you would want to switch them to divide by 2 to get a sub-Q or IV dose. And then the other piece too is around managing acute pain for these patients in the ED. Don't adjust their content, just put them on a short-acting, like immediate release formulation. You'll have much easier control over things and be able to titrate it a lot quicker. Next stage. So nausea and vomiting, I will not focus on this, except to say that please remember that Haldol can be a very useful antiemetic. We use it often in first line in palliative care. And if you have an agitated, delirious patient who's also nauseous, it is a very clean choice to start with Haldol. Next slide, please. So I want to talk a little bit about palliative sedation, because a lot of these patients require it. And right now, this is not something that you would be expected to provide at this stage. But our palliative care program has thought ahead to a scenario like Italy or New York, where we are overwhelmed and you are overwhelmed, and there is a scenario where perhaps physicians in the front lines and ICU admitted patients in the ED would need to provide this for patients who are dying. So there is a one-page cheat sheet for palliative sedation that we have put together and have made available, again, to the Calgary zone, and probably not provincially, because there's some practice differentiations amongst our regions. So I want you to have an awareness of it. Currently, our AHS guidelines are to have a mandatory palliative care consultation when you think a patient might require palliative sedation. The wording on the document is that I would ask that you strongly consider it. So at this stage, I want you to know about it, to know what medications we might use, but please to call us if you think that somebody has refractory dyspnea or agitation. So just to define palliative care sedation, it is the use of sedation to treat refractory symptoms in the final hours to days of life. It is not something to consider when we think somebody has weeks or more to live. It really is in the final stages, end of life care, when somebody's actively dying. We think about it when everything else that we have in our toolkit has failed, or there isn't time for those things to work. And it is not the same thing as MAID. It is not done with the same intentionality of that. And it's not a scheduled event. It's something that we need to do when our normal tools are not working and somebody's suffering is tremendous. Next slide, please. So the criteria that are, next slide, please. You have to have a progressive, oh, sorry, go back a slide. Thank you. You have to have an incurable condition causing severe suffering, refractory symptoms where we've tried everything, the burdens, the side effects are not acceptable to patients, or we wouldn't have time to try things that would work, which, it is maybe a little, well, no, you can still think of that as being relevant for COVID-19. The patient needs to be C2 goals of care, and you have to have a documented consent with the patient and or their substitute decision maker. And again, at this stage, I would really say, please call us if you need to think about this. And if we're truly in a phase 4 pandemic situation, that recommendation may change a little bit. Next slide, please. I usually describe this to patients and families by telling them that we need to use medications to put the patient into a very deep sleep because their suffering is so great and my usual tools are not working for them, and we will do this until natural death occurs. There is no evidence that it shortens life, and it is not the same as MAID. These patients are already dying. They've already started down that trajectory. And I'll often tell families that the goal isn't to shorten the road, but to smooth out those bumps in the road until natural death happens. The other important thing for families to know about is once we're talking about it and considering it, and then when we embark upon it, the patient will not be able to communicate and they will not wake up again. So if there is a conversation to be had, if the patient's even able to, they need to know that they need to have that before you start providing palliative care sedation. Next slide, please. So we use typically midazolam, and it works well most of the time. The scenario that I think of in the emergency department is somebody with terrible dyspnea who's actively dying, and you may need to bolus or push midazolam at the bedside as they're dying. And you can give them 2.5 to 5 milligrams basically every 5 to 10 minutes. And sometimes these patients will die very quickly. If there's any question about that, at the same time as you're doing that, an infusion can be hung, and then we usually run it from 1 to 10 milligrams an hour, sometimes more than that. And we titrate to a RAS goal of -4, -5, so basically unresponsive. And then you need to watch, and if the RAS goal is not being met, you continue to bolus midazolam every 10 minutes to get there. And every time you need to bolus, then you can increase the infusion by 1 milligram an hour. Midazolam, of course, has the possibility of a small percentage of patients having a paradoxical reaction. And it gets tricky with that because you don't know if you're not giving them enough or if they're truly becoming more agitated from it. So typically the response would be to continue to increase it until it becomes very clear, at which case you may need to add in another medication. Next slide, please. We use methyltrimeprazine as a second-line agent, either in place of or in addition to midazolam if it's not sufficient or there's paradoxical agitation. And again, we schedule it around the clock every 6 hours and have it available Q1H PRN. It's also important to know for Nazanan and for phenobarbital, which is on the next slide, you can pull that up, that we are potentially looking at a medication shortage of midazolam, which is why I mentioned these 2 other medicines that we commonly use in this scenario, so that you're aware that that might be why we're using them, or there might be a scenario where that's what we have to use as a first-line agent. So phenobarbital will often add that as well to midazolam. It, of course, has a very long half-life, and I usually will start it at 60 milligrams Q12H and move up to Q8 and then increase the dose from there. Next slide, please. So just a reminder about general end-of-life care as well. If somebody's on oxygen and they're dying and they're C2 and you've had that conversation, stop checking their oxygen saturation level. Use the oxygen for comfort, but remember that the high flow oxygen can actually be very drying and very uncomfortable for patients. So consider weaning it with the knowledge that that likely will speed up the process of dying for these patients. Stop checking vital signs, turn off the monitors, look through the medication list, make sure everything you're giving is focused on comfort, stop IV fluids. Eye and mouth care can be ordered via the C2 order set in SCM, which you can also refer to for starting points. Just know that the selections in there have analgesic dosing for opioids, so you need to be a little bit mindful if you're starting them for dyspnea, or you need to move beyond the basic recommendations in the C2 order set, but it's a very good starting point. Think about talking to social work, plus or minus spiritual care, to use video conferencing for patients and families when they can't be in the hospital. And if patients have a fever that's making them very uncomfortable, you can also use rectal acetaminophen at end of life. Next slide, please. Really briefly for care after death, this isn't something that palliative care really does a ton of, but essentially, right now, family can stay, if they're already in the hospital, so you've determined that they're dying, they have one family member present, because the visitor recommendations right now would say that if it's truly end of life, you can have one visitor. They can stay for about an hour after death, and then they're asked to leave with the patient's belongings. No additional visitors can come after a patient has died. It's very unlikely that religious or cultural practices can be accommodated. The normal viewing process that families have in the morgue is not happening right now. And just a reminder that COVID-19, a death from probable suspected COVID-19 alone is not a notifiable death for the medical examiner, unless there's other reasons that it's an unexpected or unexplained death, as per our usual criteria. So next slide, please. The palliative care consultation service in the Calgary zone. You can access us through SCM, or if you're not in hospital, through Rapid. And a reminder that during the day we have a site-specific physician or team that's available, but a citywide physician on call at night and on weekends. So it's a bit harder for us to get around in person nights and weekends. We can if needed, or we can provide telephone support. We are mostly a consultative service. Admissions should go through the regular pathway that you're aware of now through hospitalists and MTU for COVID-19 patients. You know, there may come some changes to that in a true phase 4 situation, but for now, that's what you should be doing. Please call us. You know, I'd encourage you to try the first line treatments of scheduling opioids and titrating them a little bit, or scheduling neuroleptics. And if those things aren't working, or you have complex goals of care conversations that are difficult to navigate, then please consult us. We're, I think, a very accessible group, and we're happy to have these conversations. And one more thing to remind you about this, about our service, that you might want to ask about, is that it's very difficult for us to get patients to hospice from the emergency department. And for many of these patients, there isn't even time to get them to hospice. But just know that the process for that is very, very difficult, if not impossible, especially in the context of COVID-19. Next slide, last slide. In summary, you know, I think that we as emergency physicians have the tools to already skillfully provide palliative care and end-of-life care. Obviously, I believe this, but it really is as important as providing critical care. I'd encourage you to practice your rapid goals of care conversations. Have a script that works for you ready. Treat dyspnea of lower dose opioids. If you have an agitated delirium, start with neuroleptics, and then call us if those things aren't working, and we'll help you to care for those patients. And then next slide is my references, and that's what I have to say. I hope that's helpful.
Jen, thank you very much. I think just judging from some of the comments, that is very helpful. I think there was one extra slide. Erin, can you just go one down? Okay, sorry, you're taking that out. So thank you so much for sharing that with us. I think that's certainly going to be very helpful for all patients that we see, never mind the COVID patients. But we're just going to hand over now to Sean to moderate the questions that have come in. I see several of them have been answered, but there are some specific to the to palliative care. Sean?
Great. Thank you so much, Jen. That was fantastic. First question is from Mike Betzner. With respect to palliative care being managed in hospital versus in care homes, in particular, he asks about Bethany, Hillcrest, or Boyac. Mike mentions that recently some of the physicians, hospitalists, have been recommending the patients go back to their care facility to get palliated there rather than in the hospital. Can you comment on the ability of those facilities to be able to provide adequate end-of-life care or palliative care in these patients?
Yeah, I mean, I don't work in those environments, but we do have several consultants that cover our long-term care facilities as part of our larger palliative and end-of-life care program. So specifically with respect to long-term care, I know that we do often think that we're just going to send people back there to be palliated, and we do, and they are. Is it as good or as attentive as it being in the hospital? I don't know, to be honest. And I think, Mike, you're maybe referring to all patients, like all comers who are dying, not just COVID-19, of course, because that's a bit different when you're sending somebody to a long-term care facility where there's an outbreak. they obviously have an attending physician who's typically a family physician, and they have access to a palliative care consultant who can either see the patient in long-term care and provide advice or provide phone support to the family doctors. So, is it, I don't know whether to say if it's the same or better or not. The reality is that it's very difficult for all these patients to be admitted to the hospital just for end of life when they do have 24-hour nursing support in a long-term care facility. If you're asking me what I would do for my own family members, that's maybe a different discussion.
Thank you, Jen. That's great. There's a couple questions with respect to the extubation. I think some people were a bit surprised, or it was new to them to hear to discuss the idea of not extubating patients, thinking that the tube itself would lead to a fair bit of discomfort. Can you comment on the avoiding extubation in this end-of-life care and the potential discomfort they may experience from having the endotracheal tube in place?
Sure. I'm not saying don't extubate your patients. I think I'm saying be mindful of it and why you need to do it and in which patients that would be important. And it probably has to do a little bit with how close to dying you think they are. One of the reasons we extubate people in the emergency department is for comfort, for sure, but also for family members who come in and are at the bedside, so that they don't have to see their family members with, tubes and lines and all of that. So I think you need to weigh that out carefully. Our working group nationally published some recommendations in CGEM a few weeks ago, and that was one of the things that we had talked a bit about. And I don't know what the right answer is. I do think that there is that balance between exposing care workers, and if you think it can be done safely with PPE, and the patient is likely to have still quite a bit of time measured in, many hours to short days, and they might get admitted, then yes, you would consider extubating them, I think, carefully and with proper precautions. If they're truly that, some of these patients that I've seen with hypoxemic respiratory failure who we switched to comfort care and died, they died very quickly. And in that scenario, like in minutes, especially if you're considering weaning the oxygen. And in that scenario, I don't know how important it is necessarily to remove the tube when you can escalate sedation and opioids in that scenario. So it's a thought. It is not a hard and fast rule. Nothing in palliative care is a hard and fast rule.
Perfect. That's a great sort of discussion around the nuances of when and when not to remove the endotracheal tube in these patients. That summarizes all the questions at this point. As always, we'll summarize the other questions that were answered and provide them with the link to this by next Tuesday for the newsletter and dissemination.
Okay, that sounds great. Thank you.
All right, thanks a lot, Jen. Aaron, can we have the next? So just Eileen is now going to do the wellness update on food and medicine, as medicine. Thanks, Eileen.
Thanks, everyone, and thanks for sticking around. I know it's been a long morning, so I do appreciate people sticking around for this last little segment, and I'll try and be brief. So I just wanted to touch briefly on nutrition and COVID. I think most of us would agree that proper nutrition is both the best prevention and treatment for both acute and chronic illnesses. Next slide, please. So the one topic I did want to focus on briefly was about water and hydration. And it's easy for us, especially as emerge physicians, to become dehydrated on shifts. And this is often due to infection control. We're unable to drink properly. We have at times a very physically demanding job. And we also work in an air-conditioned environment where we lose moisture through evaporation. And so this leads to a perfect storm of water loss. So I've included 2 tips about how you can increase your hydration on shift. So for every cup of coffee, you can drink 1 glass of water. You can also bookend each day with water. So have a glass of water in the morning and a glass of water in the evening. And we know that staying hydrated helps with mental clarity and helps combat fatigue. The brain is particularly sensitive to changes in water balance. And so there was a review of the limited evidence and nutrition reviews. And being dehydrated by 2% impairs performance in tasks that require attention, psychomotor ability, and immediate memory and working memory tasks. And there was also a study actually done a few years ago in the International Journal of Emergency Medicine, and it found that overall nurses and doctors lost about 0.3% of their body weight on shift. And so physicians lost a mean of 0.57 kilograms and nurses lost 0.12 kilograms. So nurses often drink more fluid, physicians often have a higher mean specific gravity in their urine, and they often visit the washroom a lot less. So there's no one size fits all category about how much you should drink. It really varies depending on your sex, your body habitus, your activity, and your comorbidities. But if you haven't peed on your shift and your urine specific gravity is approaching 2, you're probably dehydrated. And last, I just wanted to include a little blurb about, there is a lot going around about that warm water, if you gargle it every 15 minutes, that it can kill COVID. This is not a thing. Next slide, please. So in general, if you go across any nutrition organization, from the Canadian Dietitians of Canada to British dietitians as well, to the States, there's no substitution for a balanced diet. So I think every organization agrees that if you're otherwise healthy and you eat a varied diet, you really don't need any supplementation. However, there is some exceptions. And so this is the position statement that I've included here from the International Society of Immunonutrition. And they actually came out with this position statement in March of this year. And so many of our vitamins are actually very important for both T cell and B cell immunity. And so in summary, people who are elderly, people who are immunocompromised, or people who might not be able to get a varied diet would benefit from supplementation from vitamin E, vitamin C, zinc, as well as vitamin D. Now, the ranges that are listed in this position statement do exceed the daily recommended daily intake recommendations for the average healthy adult, but they're still well within the safe level for consumption. Now, it is important to recognize that mega doses of any vitamin can be dangerous, even vitamin C, despite it being water soluble. If you have a history of any liver problems or kidney problems or calcium oxalate stones, it can actually cause significant toxicity or problems. And then the other case, just to piggyback on Megan's presentation, is patients on chemotherapy as well should always review with their oncologist if they're taking extra doses of vitamins. Next slide, please. So most of these vitamins are, as I mentioned, readily available through a varied diet, especially in the context of consuming a diet rich in fruits and vegetables. And I just want to highlight a couple points on this slide. So frozen vegetables are often just as good as fresh. They're often flash frozen at their peak, so they often contain a good amount of nutrients, and sometimes they actually have higher nutrient values than fresh, because often a lot of fruits and vegetables have long journeys to get to our table. I just wanted to highlight vitamin C. So actually one of the highest sources of vitamin C is yellow or red bell peppers, and half a cup will exceed your daily recommended intake. So it's about 125% of your daily recommended intake. And if I had to recommend one supplement, I would recommend vitamin D. Often because we live in a northern latitude, many of us are deficient, and it can be somewhat difficult to get vitamin D through our diet. It's found in fortified plant milks, milk, margarine, and of course the sun. But for this reason, I would recommend for most people that they do take a vitamin D supplement. And some might actually argue that given the pandemic and other related diseases are often zoonotic diseases, that we should overall be reducing our meat consumption. But this is a whole other topic that we won't address today. Next slide, please. And very quickly, I just want to touch base on food security. And this particular concept is very near and dear to my heart. In a past life, I was a dietitian, and I worked with food providers on the downtown east side. And I also worked in northern remote communities in the Arctic. And I worked with HIV positive pregnant women in England. And all of those populations had one commonality, and that was the presence of food insecurity and its impacts on health. And so we are very fortunate, for the most part, that we're able to afford a nutritious diet. And for those on limited incomes, their food budget is often the only flexible part of their budget. So for example, rent and utilities are fixed. So in Canada alone, 1 in 8 Canadian households are food insecure, and 1 in 6 children are food insecure. And every major outbreak in recent history, from Ebola to SARS to MERS, has had both direct and indirect negative impacts on food security. So we can clearly expect the same from COVID as well. So I just wanted to highlight that there are some vulnerable populations that we can think about, and maybe even just being good neighbors. If we have an elderly neighbor, if we have a single parent with small children, maybe looking out to assist those individuals. And I have included 2 links here. One is from Food Secure Canada, and this is a Pan-Canadian Alliance of Organizations. And I've included the Google document of organizations across Canada and what their wish lists are as far as donations. And I've also included the Calgary Food Bank link as well, and they always appreciate monetary donations. And lastly, Lester McCure wanted to just to let me announce that his daughter works for the Cactus Club, and they're offering an AHS discount for healthcare workers. So please look into that if you're looking for a healthy and quick meal. And that's it. Thank you very much.
All right, thank you, Eileen. Just to remind everybody, that the Wellness Hub, Eileen, do you want to just go through your little summary slide just for links for people?
Sure. Yeah, absolutely. So essentially, we always have a link in the Tuesday newsletter with our upcoming activities and health links. The Physician and Family Support Program is obviously a very important resource through the AMA. And lastly, we have created a Slack channel with various resources from diet and exercise to humor to accommodation resources. So please check that out as well.
All righty. Thank you very much. That was super helpful. Just that reminder is great. So we got to the last slide. Thank you for staying with us. I would just like to remind you, we will be doing this again next week. And our topic for next week, we're looking at just sort of summarizing what we've learned in the last 6 weeks or so. So some sort of versions of the important things we've learned from simulations through PPE in a COVID Pearls update next week. So please sign up for that and come back and join us. Remember to send us your questions. If there's anything specific, Sean will get out the Q&A of the questions that we could not cover in this particular segment. And then just another shout for the Spectrum app. And I think that will wrap that up. Thank you very much. Goodbye. See you next week.